with this said, I'm very happy to see the responses that we got. If anything, anyway, it's not really that surprising because it tells us that thankfully we have good access to care and good access to therapy. And it's nice to see this kind of, bell-shaped curve in regard to the different therapies that you have experience with or had experience with. And just give it a little bit of sense, no doubt that on top of the list of the systemic therapies is the aspire for and go for curative intent. Of course, we want to cure everybody if we can. And many of you brought in the transplant, either received transplant or had experience with transplant. And no doubt that this is a ultimate option for the therapy. And to try to explain it, we have to remember that the transplant is not truly about the cancer itself. It's about the sick liver per se. And when I say sick liver, it doesn't mean like it's sick, it's not doing its job, but simply it's the environment which is sick that can produce cancers. And for that reason, the transplant, as many of you know, there's certain very specific criteria which will limit how much cancer there could be. And based on those limited criteria, how much cancer there could be if the patient is otherwise amenable for a transplant based on liver functionality not being that good in general, even though some argue even in good liver function we can do that because it's really the most or ultimate cure per se, then of course we go for a transplant. As you can imagine, the transplant is a, based on ask and demand, because if we don't have enough liver, we're going to be on a wait list until a liver does take place or happen to take place. And if anything, I would start by most important message, as we all are involved, and for our dear patients to make sure that there is accessibility to organs, please at least have thought about making sure that you post yourself as a potential donor. And why do we say that? Because especially for the loved ones over here, because your DMV will be happy to post that on your card or your driving license, because you never know how it goes in life, but at least having a posting of liver donor will be very important to provide those appropriate organs for our dear patients whenever needed. The message for the patients is no doubt, number one, if you are amenable to a transplant and eligible to a transplant, and of course you are keen on having transplant, of course, the transplant teams all around the country are always readily available to really help you out in every way they can. And no doubt that's going to be a little bit of a patience game, but at the same time, you have to have faith, because you never know when you might get your liver, and you probably would be getting your liver at the time where really you're probably expecting it the least. And as you all know, there are certain criteria, no need to go through them today, but those are involved in that experience, and trying to cover everything in the 20 minutes we have. But those are involved in that experience. They know very well about the scoring system that will permit them to be higher potential eligibility for the transplant versus not. And the score, of course, it all depends like how sick the liver is. And of course, we're going to always try to help who really need the help the most. On the other hand, it's very important, the counteract to this is, please, we need to make sure, remember, that if we don't get transplanted, it does not mean that's it, we're giving up. Absolutely not. There's still a lot of things that we can do. There's a lot of therapies that are available, including curative ones, which we'll talk about in a second. But it's not like transplant or no, this will be the answer. Clearly, it's not. Not only that, but one of our biggest fear is that sometimes we might actually push for a transplant or really kind of squeeze things for a transplant. And guess what? It's not going to work. And there'll be a recurrence of cancer. And this is a very important point, especially with the advent of what we're going to talk about quite a bit in a second. Immunotherapy is going to be very critical, because we cannot give immunotherapy for a transplanted patient, because we are actually unleashing the immune system against the body. And if you have immunosuppression to protect the liver, which was donated by a foreign liver / from another person, this can really create a little bit of a complexity that will not permit us to get therapy. So for that reason, we have to really put it within the context of what's needed. We like to get transplant, but even we don't give it, it does not mean we're giving up. There could be other options as well. So what are the other options? No doubt that other than transplant itself, there's surgery, we can definitely ask our expert surgeons, wherever they are around the country, to really have resection of the tumor itself. And this by itself can be having a curative intent, and patients will be cured hopefully from it, and then will carry on. Another option is radiofrequency ablation. This means that we're ablating the tumor, we're killing the tumor by radiofrequency. And this is really specifically that procedure is contrary to what we talk about intermediate stage, i.e. local therapies. This is a procedure which is made for curative intent. This is a curative surgery. It usually applies for a small tumor like 2 centimeters or what have we. Instead of going for a big surgery, we'll just do the ablation itself. And by all means, these two therapies would be available if, again, and this is a message that we heard from our colleagues like Dr. Guy and others, please, very important that if we have a situation of hepatitis B, hepatitis C, make sure we do go for screening, because the earlier we find things, the better we can have a curative intent as we're talking from the surgery or the RFA as well. Now, one of the questions that many of us ask and many of our dear patients will ask, okay, I get the surgery, now what? And sadly, this is one thing that we're still working on. We're trying to get an answer for everybody is, can we add what we call adjuvant therapy? ADGUVANT. Adjuvant therapy means like an enhanced therapy that will prevent any potential recurrence of cancer. It's not because like the surgeon did not do a good job. Absolutely not. This is really a great surgery, but sadly, cancer cells can float somewhere, and it will be a good idea to kill them before they become established a new home, especially in the liver. We don't have that data yet. We tried in different ways. We don't have good results on it. We're still working on it. And if anything, like, for example, Dr. Grunton, who's going to talk to you in a second as well from the NCI, Dr. Grunton, myself, and other colleagues, we're all trying to do these things together. And if anything, it will probably, hopefully get an answer, but we just have to wait for it. But for now, there's no answer for systemic therapy as a adjuvant therapy. We just have to be a little bit patient and see where this might take us. So be patient with it, but not feel despaired if we don't have systemic therapy as adjuvant therapy yet. We'll get to it. For now, make sure, however, you continue to be screened and followed by your doctors after the surgery or the RFA. Now, let's assume that the cancer is in the liver. It's not really spelled out of the liver, but at the same time, maybe close to blood vessels, doesn't look really in the best of places. And as such, there'll be kind of like a question about, can we control it still, despite it's only in the liver? And the answer is, yes, we can. And this is a very important point. Actually, most of you answered that they had experience with the local therapies, and we're not surprised. Because if anything, we have many different approaches, among which some of them that you either had experience with, or you're talking about with your doctor, or you had experience with, including chemoembolization, where you give an embolization plus chemotherapy. What is that? Simply what we're doing is, because for an important point, the embolization is a way to kill the tumor that feeds mainly on the blood from our artery, from the blood supply of the hepatic artery or liver artery. Interestingly, because we have dual supply in the liver, because all the blood below our liver in our body get cleaned up in the liver, this is the venous blood or the vein blood. It's still blood. It's not the cleanest, but it's still blood. And we can depend on that. So if we embolize, i.e. we kill the blood supply on the cancer cell, on the arterial supply, we can depend on the venous supply. That's really the kind of, big plus that we have for liver cancer, which we don't have in any other organ. So with this said, the embolization will apply that little beads that kind of like, will try to surround the tumor blood flow, and it will kind of kill the blood flow to it and the tumor die. And we call it chemoembolization because those little beads were also either having embedded in them some chemotherapy or infused some chemotherapy before them. We can do it, actually, believe it or not, there's data also it can be done without the chemotherapy. It can be done simply just by killing the blood supply. And there has been studies, some of them came out from here, from Sloan Kettering. There was no difference at all in regard to with or without chemotherapy. We, however, respectfully defer to your doctors because there could be some other arguments why this or that, but at least this option is available. Or you can also add radiation therapy to the little beads. So it become what we call, and some of you know about that, radio embolization. Same concept, same process, but simply we're having now little radioactive material in those little beads rather than just either inert, bland, or with chemotherapy. In regard to local therapy as well, even though it's a little bit of the latest comer to the field, is radiation therapy. Because historically, we always were nervous about giving radiation therapy to the liver, because the liver, as you can imagine, is a very soft organ, and you don't want to kind of like, hurt it or cause a problem or damage more than what we have. But now with the advent in regard to the radiation therapy, there's a little bit of better understanding on it. There's a lot of data coming on in that regard. We could not really say it's a automatic standard of care, but definitely it's kind of, doing its kind of, or contributing its presence through the great work happening from throughout the world to really establish itself as a therapy or a local therapy for liver cancer. Now that we spoke about transplant, we spoke about the surgery and radiofrequency ablation, we spoke about the local therapy being chemotherapy with embolization, we spoke about bland embolization, we spoke about radiotherapy with embolization, and we spoke about radiation therapy. Sadly, still, despite that, as about a quarter plus of you said they have experience with systemic therapy, sadly, the disease can still recur. Even after transplant, even after systemic therapy, even after surgery, even after radioablation, even after local therapy, the cancer might come and spread even to other organs. Actually, even if it's still in the liver only, systemic therapy might be even more valuable than local therapy. There are some theories. Among one of them is, to a certain extent, if the tumor is limited to a certain number of lesions in the liver and size of the lesion in the liver, there has been data that showed actually systemic therapy might be more important than local therapy. And of course, as we said, some people will have the need for local therapy because of the spread to cancer already. The good news is, thankfully, and the good news is, thanks to a lot of credits over here, I can't tell you how important this is. Over the last probably close to about 20 years, we were able to bring in so much therapy for liver cancer that really, thankfully, all does a great job. It all started with an attempt for chemotherapy. It did not work. Chemotherapy in that disease does not really do a good job. There is some exceptions for some work on specific form of chemotherapy, but really it's a default only if we really need another option of therapy. But the more important is we were dependent on certain magic pills that are called tyrosine kinase inhibitor. SA inhibitor, it's a biologic therapy that really will go after a specific target. And you probably are very familiar with the name of one of them. It has been with us for the longest time, called sorafenib. And there is another one called lenvatinib, which is more novel than sorafenib and even probably more potent, even though they're equal in regard to what they can contribute, but still has certain added potency. And of course, there's others as well, among which a drug that's called regorafenib, but this will require prior sorafenib exposure and prior tolerance to sorafenib, so a little bit conditional. Another one's called ramucirumab, which again require a certain important limitation, like alpha-fetoprotein regard needs to be at about a higher in a certain level. So this is great, but add to this, there's one which really, I have to admit, it fascinates me always the most, not because I kind of led that effort worldwide, but because really it was quite amazing. It was the only one without any conditions. It's called cabozantinib. And cabozantinib can be given not only in what we call second-line therapy, in other words, after we tried something else like lenvatinib as first line or anything else, but can be also used in third-line therapy. It's the only drug approved in third-line therapy. And by all means is well tolerated as well. These are all pills, and you probably will see your doctors probably prescribe one or the other. However, a very even more advanced part of the story, as you probably are aware of and some of you have experience with, is immunotherapy. And that's really a great, great event that we are all very happy about and very proud of. To explain to you what immunotherapy is, and it's very important, immunotherapy is not like we are trying to send immune cells ourselves. No, the immune cells are in the body already. All what we're doing is we're training the immune cells in your body to fight the cancer. Think about it this way. The cancer, pick up the phone and talk to the immune system saying, guys, we're friends, don't bug us, we don't bug you. And that's why Interestingly, our immune system doesn't attack the cancer, even though technically it's foreign. However, what we do is we kind of like, enhance our own immune system by the immunotherapy. I always jokingly say that as if like the cancer being the nice guy will give a nice chair for the immune cells to sit on, and this way they don't touch the floor or the surface of the cancer cell. All what immunotherapy is, think about this way, is kicking that chair out so the immune cell will fall onto the cancer. That's all what it is. I'm probably simplifying it. It's way more complex than that, but this is really the basics of it. Interestingly, though, we tried the immunotherapy by itself. We were very excited about it. And however, we discovered not too quick, after a lot of attempts, and to give credit for all the efforts that have been done by everybody, that by itself does not do the job. If anything, it would require, or does do a job with certain equivalents to the pills that I just spoke about, like cabozantinib, lenvatinib, sorafenib, etc. On the other hand, though, it does do the job and do even a better job if we kind of add another drug to it. That's a very interesting important component. You remember the story about the cell on the chair, and we were trying to kick the chair out so the cell can fall to fight the cancer? Well, guess what? That kicking of the chair, as we said, is not enough by itself. It requires a phone call from the upper chain of command. Some boss up there, wherever in the immune system, mainly in the lymph node or through the pathway from the lymph node to the cell, has to send a specific message, kick that chair out so the immune cells can attack the cancer. Good combination that I'm sure you heard about. One of them is what we call atezolizumab plus bevacizumab. That's one of them. And many of you probably are on it already. Another one is one that was relatively recently reported. It's called durvalumab plus tremelimumab, even though between caveat here, it's not yet FDA approved, but the data was reported positive. And sadly, some of them did not do well. And we heard lately in Paris about some of them that did not do the good job in that regard. It doesn't matter. Most importantly, as you see, this is a big plus, is that there are way too many options. And if anything, your doctors definitely will be able to offer you way too many therapies. Could there be like, I'm confused, there are too many options over here? By all means, we do understand that and we do recognize that. And yes, there could be certain assets that are important in that regard. Your doctor might bring in like, oh, what's your risk factor to begin with? What's hepatitis B or hepatitis C? What's your other immune system working? Is it against any immune disease or what have you have? Very important one, do you have any varices or bleeding potential in the esophagus? This is what they do endoscopy. And it could be that the drug has certain antibodies in your body against it. And a lot of variables over here, not to overwhelm you with them, but it's very important to have that open discussion with the doctor to understand really why we're choosing whatever we're choosing, why at the same time we are not choosing what, for example, we selected not to. And your doctors, I'm sure they will be super capable of telling you exactly what their argument behind any of them. So with this said, we can really conclude that, number one, thankfully, we do cure patients with liver cancer. Sadly, not everybody, there will be some that will get only local therapy, but to their credit, it can control the disease. And at the same time, patients who recur with the cancer or present with advanced cancer to begin with, the good news is, and this is really, really, I can't tell you how they like them. I kind of will tell you, many of us have been in this disease field forever. And it's beyond grateful to us to see that we have options for our patients to make sure that we treat their cancer and keep them going in their life. So good news, and we have options, and we're happy to always talk to any of you about all of them.